So hello, the future of resuscitation, because that's you guys. Am I going to talk about ECMO, fancy technology, flying droids? No. I'm going to tell you what you need to do in the future, and that's going back to the basics. This is the formula of survival. We need science, we need education, and we need to implement what the science teaches us. What do we do today? The best systems in the world still have an overall survival rate of around 20. And if you look at the formula, you can see what's lacking. Education. We don't teach people to do the utmost best they can. Local implementation. It was 175 years ago, Semmelweis said, guys, wash your hands. Are we doing it? No. So I hope that you do a better job in the future and implement faster than we've been able to do. That's how we get the formula of survival, the facts getting better. So where to start? Know your patient. We've known for years that 50% of our cardiac arrest patients actually have signs and symptoms 4 weeks before they arrest. We know that 90% of these with signs and symptoms have those very close to their arrest. But do we have a risk prediction instrument? No. So it's, like a sudden cardiac arrest, which could be prevented in many ways. That's why we need a new kind of chain of survival, looking also at prevention and assumption of that this guy is in risk of having a cardiac arrest. Are we the same? No, we're not. So why do we do the same thing for most of our patients? I know that there was a Twitter, somebody else likes Obama. This was the time when the president said something clever. One size doesn't fit all, and we should realize that also in resuscitation. And we need to have precision medicine also when we resuscitate cardiac arrest. Even such a simple thing that optimal hand position varies so significantly that we should really try to find tools to make the resuscitation more individual. The most important thing we need is a culture of excellence. We should decide that nobody in VFib can die. And if that happens, we should go back and see what went wrong. I don't think we do that. We always say that we did the best we could. We should do the utmost best because it's the patient that is the focus. So what do we need? We need the chain of survival, we need the formula of survival, which means that we need leadership. Even in a basic like BLS situation with 2 persons, the one should be a leader. And if you don't believe me, read my studies. It shows it very clearly. We need training, we need quality improvement, and we need a culture of excellence, which means that we should build up a system to save lives. It's not about only individuals, it's about good individuals in a good system. This is culture of excellence. We talk a lot about the community, we talk about the laypersons. We train laypersons, we find technology to involve them, to help. I would take you back a little bit and look at the professionals. We talk like there would be laypersons and then professionals. In my world, there's laypersons, those professionals that know cardiac arrest, and then there's the rest of the professionals. And the rest of the professionals are not doing a very good job. I asked in a survey of people working in the pre-hospital setting and people working in a hospital setting, what do you think these red guys would do if somebody of them would hesitate to screw open a bolt or hesitate to take a tire and change that? 20% of our personnel actually doesn't feel comfortable in starting CPR or defibrillate? Who's the weakest link of the chain? In my study, which is still the only study actually looking at how healthcare professionals perform when they call the emergency number. And why is this the only study? I don't know. They always exclude healthcare professionals saying that those guys know what they're doing. They don't. You can see group 1, doctors and nurses, they actually have less survivors after they call 112. And they have more unexpected cardiac arrests when the EMS troops arrive. And why is that? Because they so seldom actually see cardiac arrest. They cannot be professionals in those scenes. We need to teach them really easy things so that they can help us save the lives. So what do we need to do in the future? We need to make the choice to be extraordinary, to build up a culture of excellence. And not even the best systems in the world has everything in place. Not even Seattle. They have lots that they could take in also. So we need to take the jump from our current culture to something else. And it's you and your system that has to do it. There's a way that you can get help. ILCOR is doing the science treatment recommendations together with your councils. There's a global alliance, which means that the resuscitation academies all around the world are doing a good job together to try to implement the science into education and your systems. So 10 steps to improve. We shouldn't look at the resuscitation like we do. You know, we should be all of us there. The preventionists, the intensivists, the pre-hospital people, because the boat will sink if we do not all realize that we need to shovel out the water. I will show you a remarkable story of a little place in Switzerland that decided to be a culture of excellence. They had a 16% survival rate, which is very good in many comparisons. 38, then nothing really happened. They were in the good league. Then they went to have a resuscitation academy, and look what happened. And they have been going beyond 55. They're now almost up to 60. And this happened because they have a system that snatches the life of the jaws of death. And I hope you will be one of those. Thank you.
Thank you so much, Maaret. That was fabulous. Heini?
A lot of discussion, on leadership and what the future will hold. But specifically, what is something simple that a hospital system that doesn't have ECMO, just a standard hospital system, what's the simplest thing that they can do tomorrow to make resuscitation even better?
Well, I would say that BLS is the basics of all the resuscitation. So get people to start without hesitation. Compressions only if needed. Then you have a team coming in, anesthesiologist or somebody help you. But start fast without thinking so much about, if it's alive or not, because they will tell you if they're alive. Do not push. So I would say really the basic things. Compressions, AED, a very simple model, start, and then you have time to take in more experts from other wards.